Alright, so part 5 of chapter 21, hopefully it's the last part. Here we're just going to talk about disorders of platelets. There are two major disorders of platelets, thrombocytopenia, which you see on this slide, and then on the next slide is going to be alterations in coagulation. With thrombocytopenia, the issue can be either, or a combination of, increase in destruction or decrease in production. So the thrombocytopenia, you have a platelet count of less than 1,000 per millimeter cubed. The symptoms are going to be bruising and petechia. Petechia are the very small hemorrhaging, or hemorrhages you might see on the skin that look a little different than an actual bruise. The causes of this is injury to or disease of the bone marrow. It can be an autoimmune disease, and so you could actually have antibodies that develop against your platelets, and so then the platelets are targeted for destruction. Hypothermia, and then viral or bacterial infections. And then these can cause intravascular coagulation, which we'll talk about in just a couple of slides. So, decrease in the platelet count. All right, now, looking at alterations in coagulation. With alterations of coagulation, you can have two major underlying issues: vitamin K deficiency and then liver disease. So, this would be classified as inadequate platelet function, and it's characterized by an increased bleeding time in the presence of a normal platelet count. It is most commonly the result of drugs, such as aspirin, non-steroidal and anti-inflammatory drugs. Can be an issue with antibiotics, cardiovascular drugs, psychotropic drugs, anesthetics, and even some foods. Some systemic disorders that affect platelet function include uremia, which is then going to be an issue of renal failure, autoimmunity disorders, leukemias, myelodysplastic syndrome, and cardiopulmonary bypass. A diet can affect platelet function as well because of the vitamin K deficiency. So, clinical manifestations: petechia, purpura, bleeding from the GI tract, the genitourinary tract, pulmonary mucosa, as well as the gums. So, vitamin K deficiency, a relatively uncommon condition that interferes with the synthesis of prothrombin, coagulant factors, and anticoagulant factors, so that the hemostatic balance between coagulation and anticoagulation is lost. Many individuals with this deficiency will experience easy bruising as well as excessive bruising or excessive bleeding. Parenteral vitamin K administration effectively treats this order, so simply injections of vitamin K. Warfarin interferes with the action of vitamin K. And individuals who are excessively anticoagulated with this drug may require vitamin K administration to prevent hemorrhaging. All right, we get some vitamin K from our diet. We also get vitamin K that is processed properly from the bacteria in our gut. And so there can be issues following broad-spectrum antibiotic use because those broad-spectrum antibiotics kill off the bacteria. And so then you deplete this avenue of pulling vitamin K into your body. All right, then liver disease. Liver disease causes a broad range of hemostasis disorders, be it defect in coagulation, fibrinolysis, platelet number and function. Liver disease prevents the normal synthesis of clotting factors and increases fibrinolytic activity. In addition, liver disease may cause thrombocytopenia and alterations in platelet function. All right, so that's the coagulation. Individuals suffering from advanced liver disease experience easy bruising and excessive bleeding to trauma and surgery. And this is different than a person like me who might get a bruise and it looks pretty nasty, but I have no idea what happened. Right? That's not the easy bruising that people are talking about when they talk about disorders of platelets. All right, and the last one is this disseminated intravascular coagulation. This is a very complex and acquired disorder in which clotting and hemorrhaging simultaneously occur. And there's a fair amount of information in the notes section that you can read through. DIC is the result of increased protease activity in the blood caused by unregulated release of thrombin with subsequent fibrin formation and accelerated fibrinolysis. So, what you have is this combination of too much clotting and too little clotting as a result of platelet activity. And so clotting leads to blockage of blood flow to organs throughout the body. That clotting causes consumption of platelets and the clotting factors, leading to severe bleeding in other areas of the body. In the presence of DIC, a seeming paradox exists. That is, systemic clotting in the presence of bleeding. So you have both occurring at the same time. Simply stated, systemic coagulation consumes the clotting factors and platelets. And at the same time, the clots are being broken down, that's the clot lysis, due to the anticoagulant effects of fibrinogen degradation products, the FDP, which can lead to oozing of blood or, in severe cases, hemorrhaging. All right, so then, end result, you have tissue ischemia and then significant hemorrhaging. All right, so again, it's this paradox, too much and too little clotting at the same time. So too much clotting, excessive and widespread exposure of tissue thromboplastin. This is due to vascular damage, inflammatory cytokines, even tumors that can secrete these different materials, specifically the thromboplastin. There is naturally a decrease in the anticoagulants that are going to be circulating, and decreased rate of fibrinolysis. However, at the same time, then you have too little clotting, which leads to bleeding because of the high consumption rate of platelets and clotting factors that exceeds the production, therefore the paradoxical increase in bleeding. And then there's a slow breakdown of fibrin that creates degradation products that act as anticoagulants. All right, so this is a slide, figure 2119, and you need to look at this and understand the process. So at the top you have different issues. It could be trauma, sepsis, cancer, products of conception, injury to the endothelium, and this causes injury of the endothelium causes direct platelet aggregation. And you've got actually quite a few good figures in chapter 20 that look into this process. So endothelial damage, you have the inflammatory cascade, release of tissue factor, massive activation of the clotting cascade. So then you have widespread microvascular thrombosis that activates plasmin, which causes fibrinolysis, and then you have lysis of the clotting factor, creates fibrin split products, and that is the anticoagulant. So an inhibition of thrombin, platelet aggregation, fibrin clot. Going back up here to the widespread microvascular thrombosis, you have vascular occlusion, microangiopathic hemolytic anemia, consumption of platelets and clotting factor, which leads to bleeding, and then ischemic tissue damage. So you can see where or how you have this disseminated intravascular coagulation, too much clotting that then initiates or allows too much bleeding, and a person ends up having ischemic tissue damage.